All right. Well, good morning, everyone. Thank you so much for inviting me to speak with you all today. My name is Bobby Rudock. I am a sleep physician at WashU in St. Louis, and I'm really excited to be talking to you today about the relationship between sleep and seizures. This is really one of my favorite topics. My background is in pediatric neurology. After my residency, I did fellowships in sleep and also epilepsy. I see primarily sleep patients. The reason I did an epilepsy fellowship several years ago was because I really enjoy taking care of patients who have nocturnal spells. And there's, as you guys know, a lot of overlap between seizures and parasomnias. I also really find that this overlap between these two topics is just really, really fascinating and something that continues to be explored and we continue to learn more and more about. So I'm hoping to kind of share my knowledge with you in a practical way. I'm going to try to keep this kind of high level concepts so that you can take what we talk about today and apply it to your clinical practice. Seizures, EEG, and all of that tends to be a rather intimidating topic for most sleep fellows, especially at the beginning of the year and especially for non-neurologists. So hopefully after we're done talking, you'll feel a little less anxious about tackling some of these more challenging patients and cases. So I have no disclosures. I was asked to put together some learning objectives, and here are the objectives. After we're done talking, hopefully everyone will be able to appreciate how state can influence seizures and epileptiform discharges. State is, are you awake? Are you asleep? And if you're asleep, are you in stage 1, 2, 3, or REM sleep? We will review how anti-seizure medications can affect sleep in many, many different ways. Hopefully, you'll then be able to also recognize that patients with epilepsy are at an increased risk for specific sleep-related problems, the biggest and most important being obstructive sleep apnea. And then also at the very end, we will work on developing a framework to evaluating and tackling the workup of patients who come to you with nocturnal spells. Along the way and throughout my talk, I'm going to be sharing some EEG tips as well, because this is something that our sleep fellows here often ask me about. So I'm hopefully going to share that with you all as well. So let's start with a historical quote. So thousands of years ago, Hippocrates said or wrote, "A patient with epilepsy should spend the day awake and the night asleep. If this habit be disturbed, it is not so good. Worst of all, when he sleeps neither night nor day." So even back thousands of years ago, people were recognizing that there is this interesting relationship between sleep, seizures, epilepsy, and all of the above. If we look at certain epilepsy syndromes, we can also appreciate this relationship between sleep and seizures, but perhaps in a more circadian way. Right here, I have listed a handful of epilepsy syndromes, and I'm just going to kind of describe when the seizures tend to occur. So in juvenile myoclonic epilepsy, also known as JME, which affects more adolescents and young adults, they have lots of different seizure types. One of those seizure types is myoclonic seizures, which are little jerks of small muscle groups. And usually the story we get from a patient is that when somebody is brushing his or her teeth in the morning, they drop the toothbrush, and that's a seizure. And so these myoclonic seizures tend to occur more often in the morning. Epileptic spasms is formerly known as infantile spasms. You guys may have remembered this from medical school. And these are seizures that cluster after waking up. And when I say cluster, I mean they happen one after another, kind of grouped together over a short period of time. These tend to occur more often in the morning after waking up or after naps after waking up. And this occurs in young kids, really babies. In benign childhood epilepsy with centrotemporal spikes, this was formerly known as Rolandic epilepsy. These seizures tend to occur the majority of times during sleep. So about almost 80% of the seizures will occur during sleep. For the focal seizures, those can sometimes be rather subtle. So sometimes the patient is sleeping and you'll just have facial twitching of one side. In Paniatopolis syndrome, this is a pediatric epilepsy syndrome. The seizures occur more often during sleep and are often associated with vomiting. So if you get a story about a kid having a spell at night and they're vomiting, it very well could be related to this epilepsy syndrome. And then the last one I just want to point out is sleep-related hypermotor epilepsy. This is formerly known as nocturnal frontal lobe epilepsy, which is the classic one that most of you will be talking about and learning about this year. These seizures occur exclusively during sleep, meaning you don't have any seizures when awake. The hypermotor component of this really just describes what the seizure looks like. And oftentimes it's a lot of arm and leg flailing in a non-rhythmic type way. So these look very different than what a seizure would look like when awake. For example, a generalized tonic-clonic seizure, where you have stiffening followed by rhythmic shaking of all your extremities. This is a nice figure that further illustrates how different parts of the brain are more or less likely to have a seizure at different times of the day. Note that when we're talking about different parts of the brain and seizures, where a seizure arises from will dictate what the seizure looks from. So when I talk about what a seizure looks like, that is called the seizure semiology. Let's look at this figure a little more. So on the left most portion of the figure, we have the time at 6 a.m. Then as we move from left to right, we have noon, 6 p.m., midnight, and then 6 a.m. So this is over a 24-hour period of time. And what we see is an interesting pattern. Around noon, we see that if you have occipital lobe seizures, this is when those seizures tend to occur most often. Presumably, this is not related to any kind of circadian component, but this may actually be related to the fact that at noon, in many parts of the world, the sun is at the highest and it is the brightest outside, and you can have light-induced seizures. And so that's why we see kind of this peak around noon, maybe slightly over to like 1 p.m. Next, I want to kind of direct your attention to the right side of this figure, where we're looking at frontal lobe, parietal lobe, and mesial temporal lobe. These are the seizures that tend to occur more often at night. And so you can kind of appreciate at night between, maybe 10 and 6 a.m., we see this clustering of these types of seizures arising from specific parts of the brain. Frontal lobe seizures tend to occur more in the early parts of the night, so soon after going to sleep, and parietal lobe and mesial temporal lobe seizures tend to occur closer to the early morning hours. So when I'm thinking about a patient with potential seizures and I'm getting a history about what's happening at night, when it happens in the night is something that I definitely keep in mind in terms of what it could be. Could it be a seizure versus could it be a parasomnia or something else? And if I think it's a seizure, knowing when it occurs and what it looks like can help me maybe figure out where in the brain the seizure is coming from. For frontal lobe seizures, again, these are the classic hypermotor seizures where you have more flailing of extremities. I've had some patients who will jump out of bed and start sprinting through the house, and that's a frontal lobe seizure. Parietal lobe seizures can be much, much more variable, though. Parietal lobe seizures can look, quote unquote, very weird and tend to not be as stereotypic as some of the other seizure types. Sometimes a parietal lobe seizure can manifest through just confusion in the night or weird sensations in various extremities or parts of the body, such as numbness or tingling. Mesial temporal seizures, usually the history we get is somebody wakes up and then they have this feeling in their belly, like an epigastric rising feeling or a feeling of nausea that slowly gets worse and tends to evolve or change into another type of movement. So as you can see overall here, we have this interesting relationship between all these different seizures, all these things that we've seen historically. So we know there's this temporal relationship or timing relationship with seizures, but what about epileptiform discharges? So I'm going to back up briefly and just mention what an epileptiform discharge is. So an epileptiform discharge is an abnormal electrical discharge arising from the brain, and it clinically suggests that there's a lowered threshold for a seizure, meaning you're more likely to have a seizure than somebody without discharges. There are two big kind of categories of discharges, generalized discharges and focal discharges. So this figure on the bottom left is looking at just a bunch of EEG tracings. And what you see is that you see these discharges occurring in all the EEG channels. So it's generalized, meaning it occurs throughout the entire brain. That's different than a focal discharge that occurs in one part of the brain. So over here on the bottom right, what you see is that the discharges are occurring in about half of the EEG electrodes. It's not everywhere. So generalized occurs throughout the entire brain. Focal occurs in one part of the brain. Okay. And usually for a seizure, it starts off with a discharge that looks something like this. All right. This is also important because in things like frontal lobe epilepsy or hypermotor epilepsy, those seizures tend to be focal. All right. So this is one of the reasons why we actually want to try to capture sleep on our EEGs. This was a great study that went back and reviewed a bunch of articles looking to see, well, if we know a patient has seizures in epilepsy, when are their discharges most likely to occur? So what they did is they categorized generalized discharges, which is this top table, versus focal discharges. So let's focus on this top table first. So if we take all the discharges that occur in patients with generalized discharges and we look at when they occur throughout the day, what we see is this. About 23% of those discharges occur during wakefulness, and the remainder occur during sleep, meaning the vast majority of discharges over a 24-hour period occur during sleep. Again, this is why for routine EEGs, and when we get EEGs, we really want to capture sleep, because sometimes we don't see anything during wakefulness. But then when the patient goes to sleep, we see lots of discharges and or seizures or other abnormalities on the EEG. So for generalized discharges, again, 23% during wakefulness. There's a slight decrease during stage 1 and stage 2 sleep of non-REM, but then during stage 3, it blows up to 56%. So the majority of discharges that a patient has tend to occur during stage 3 sleep. In this particular study, they said no patients had any discharges during REM sleep. I don't think that's really true. I think this is just a small sample, but just appreciate that during REM sleep for generalized discharges, you are less likely to see something. When we look at focal discharges, the pattern is slightly different. So during wakefulness, you only see discharges during or 6% of the discharges occur only during wakefulness. That's much lower than 23. We see the same pattern where during stage N3, we see a lot more discharges, almost 70% of them occur during then, and then it drops off a little during REM sleep, although it's still a little higher compared to wakefulness. So the big picture here is that the majority of epileptiform discharges occur when the patient goes to sleep, and during sleep, the majority of discharges occur during N3 sleep. So what does this look like in practice? Okay. This is a patient of mine who's a young adult who has known epilepsy and epileptiform discharges on her EEG. This is just a snippet with how I like to look at sleep studies with a certain montage. You can see at the top, the EEG is a little condensed, and I do that just because I'm used to looking at a lot of EEGs, and we're looking at 2 minutes a page right here. And so I know this patient has epilepsy. I know this patient has discharges, but it's hard to really appreciate or really see anything here at 2 minutes a page. And so what are we going to do? We're going to look at this from a slightly different perspective. I just want to point out, I do recognize that there's a sinus arrhythmia here. We're going to ignore that for this study, okay? So this is 2 minutes a page. And if we look at a different perspective on 30 seconds a page, we start to see a little more. So you can see up here in the EEG, there's some deflections here, in the middle. You might think, oh, maybe that looks a little funny. Maybe it could be a K complex or something else. It's really still a little difficult to see. So if we continue looking at this, let's try to blow up the EEG so that we can see just the EEG portion. It looks different yet again. Okay, right here, we're starting to appreciate that there's some sharpness and some high amplitude at some of these in some of these deflections, but it still doesn't look like that classic spike and slow wave that we always read about, that we always see in the textbooks. When I was in training, I always would get frustrated by things not looking exactly how they were supposed to look. So what we will do next is we will kind of zoom in a little further. And so instead of looking at it at 30 seconds a page, we're going to look at it at 15 seconds a page and just look at the EEG. And now we can start to see that more classic pattern, okay? So what you can see in this first deflection is that the amplitude is going up in C4 and O2. And as a reminder, in the even electrodes, that represents the right side of the brain. Okay, so we have some right-sided discharges, and we have this nice spike and slow wave that we typically see. Over here, we have for the second deflection, we have another spike and slow wave, which looks like it's actually, yes, also on the right side. Over here, the third one looks like this discharges in C3, so this is the left side. So what we're doing is we're basically taking the EEG and we're looking at it close up. So what I want you to take away from here is that it's okay to zoom in and look a little closer at the EEG. I can't see a lot of the abnormalities in the EEG when I look at it at 2 minutes a page. Most people tend to read sleep studies at 2 minutes a page. You should definitely be toggling back and forth, because remember, the recommendation is to look at the sleep study epoch by epoch. But it's not uncommon to miss things if you're looking at it from so far away. So don't be afraid to zoom in and to look at just the EEG portion, because that's where you're going to start to see these abnormalities. So if we take the very same patient and we look at her EEG at different stages, looking at it at 15 seconds a page, what we see is this. This is an example from her sleep study during stage 1, non-REM 1. And at the very end of this epoch, you see a sharp wave and probably a sharp and slow wave at the very end. If we take a sample and we look at stage 2, we see exactly what we were looking at before. This is the same picture, but what we can appreciate is that the discharges are occurring more frequently during stage 2 than stage 1. And then if we take stage 3 sleep, we can appreciate yet again that there are even more discharges occurring during stage 3 sleep. All right, so what you should think, and a good rule of thumb here, is that the likelihood of seeing epileptiform discharges during sleep takes on this pattern. We're most likely to see it during stage 3, followed by stage 2, stage 1, and then REM sleep in this order. So if you're looking at a sleep study and you're wondering, is there something going on in the EEG? Do I need to be worried about that? If you hone in on stage 3 sleep, you're more likely to appreciate and more likely to see the actual discharges, because you're going to get more samples of the discharges. This is, again, just a good rule of thumb. I'll also mention that as sleep physicians, everybody here is probably going to be looking at more EEGs over your lifetime than most neurologists who are not epileptologists, okay? In every sleep study, there is an EEG. And so you're going to be looking at lots and lots of EEGs, and over time, it does get easier. Don't be afraid to look at the EEG. Don't ignore it. I know a lot of people are tempted to just ignore it and assume that the staging is accurate from the sleep text, but it is something that can give you a lot of extra information. And let's say you find some discharges in a patient who does not have known epilepsy or does not have a history of an abnormal EEG. Well, if you see discharges, that might suggest that they actually have undiagnosed epilepsy, and that could be maybe the reason why they're sleepy and showed up to your clinic in the first part. All right. So why do we tend to see this overall pattern? Well, the reason hasn't been fully flushed out, but the general theory is that brain waves, or the brain just varies in its ability to synchronize brain waves in different states, so that during non-REM sleep, the brain is in a state of hypersynchrony, and during REM sleep, the brain is in a state of hyposynchrony. This idea is supported by the following study. In the first figure here, what we see is they took a bunch of discharges and they classified them according to when were you most likely to see the discharge? Was it more likely during non-REM sleep, REM sleep versus wakefulness? And the big point here is that you see this deflection down during REM sleep. So you're least likely to see it during REM sleep, especially in generalized discharges. They then took those discharges and categorized them further. They said, okay, well, do these discharges really look like they're generalized, occurring throughout the brain, or do they look like they're more focal or only coming from one portion of the brain? And what they found was that during non-REM sleep, and this is the figure B, during non-REM sleep, the discharges tend to be more generalized, occurring all over the brain. Versus during REM sleep, the discharges looked more focal. Lateralized here just means right or left hemisphere. That's a way of looking at vocality. So during REM sleep, the discharges are more focal. This is actually of major clinical significance to a lot of neurologists, especially epileptologists, because if you look at where the discharges are coming from during REM, that's often predictive of where the patient eventually will have surgery in their brain. Okay, so it helps us actually narrow in where surgery might be effective or helpful in terms of doing something to help for overall seizure control. We can take this one step further in REM and get even more information. So REM sleep, as you guys may know or may learn in the future, can come in basically two types. You can have phasic REM and you can have tonic REM. Phasic REM is typically what most people think of. This is where you have the rapid eye movements. So if you look here in the middle, during phasic REM, you see these deflections in the eyes. Okay, this is largely a sympathetic response, which is different than tonic REM. During tonic REM, you don't always see those eye deflections, okay? And so I know we always like to look for the eye deflections, but you might not get it during all of REM sleep. Tonic REM is mostly a parasympathetic response. And so if we look here at phasic REM, what we really see is that the discharges are much smaller in amplitude and they don't spread as far. Okay, this tends to be predictive of where if a patient has epilepsy, where the seizure arises from. So SOZ means seizure onset zone. Okay, so again, this is something that neurologists will look at to help them kind of figure out where we're having seizures. All right, we're going to take a short pause, and I'm just going to kind of recap and talk about some just overall EEG approaches. So if you're not sure that there are epileptiform discharges on your sleep study, then increase the size of the EEG, look at it at 10 to 15 seconds a page instead of 2 minutes a page, and then try to seek out N3 sleep, because that's where you're most likely going to find the discharges. So that's a good approach if you have a question. Is this a discharge or is this just artifact, or am I just seeing something that's normal like a K complex? I will mention that please don't get tricked in a patient with frequent discharges, because the staging or wakefulness 1, 2, 3 REM may not be as accurate. This is because patients with a lot of discharges, those discharges often mask the normal sleep architecture. So you might not see the sleep spindles, you might not see the K complexes, you might not see all those things. And so it's possible that the staging may not be what you think it was originally. N3 can also be overscored in patients with a lot of discharges, because as you saw, the discharges tend to be high amplitude. And when we're thinking about classifying stage 3 sleep, we're looking for high amplitude slow waves. So if you don't look at it closely, you might get tricked in that way. And then be careful also with microarousals. So if you have a bunch of discharges or a seizure that occurs in a short period of time, a burst of discharges might look like an arousal. This is especially important in pediatrics, where we score a lot of obstructive hypopneas, and an arousal can be part of the criteria for scoring an obstructive hypopnea. Whenever I see or whenever I read a sleep study on a patient who has known epilepsy, or a patient who I'm the one who's pointing out the discharges that haven't been appreciated yet, I always go back in my sleep study and I look to see what is going on the EEG right before an apnea or a hypopnea. It doesn't happen often, but once in a while, what we can see is that there's a seizure that is manifesting as an apnea, or right after the seizure, there's a decrement in flow and there's a hypopnea. And so for patients like that, the treatment is not going to be your typical run-of-the-mill treatment for OSA. It's really going to be referring to neurology or talking to the neurologist about better seizure control and then reassessing, right? Because that's what's actually causing these things. All right, moving on. So I know everybody knows this figure very well. This is just illustrating what happens with the sleep architecture over the course of the night. We all know we go from wakefulness to stage 1, 2, 3, back up to REM, 1, 2, 3, and so on, so on, and so on. At the beginning of the night, there is more stage 3 sleep. Towards the early morning hours, there's more REM sleep. This is another study that grouped patients with epilepsy into 3 levels of seizure control. So this first column is looking at patients with epilepsy who have not had any recent seizures. The second column is looking at patients with good control of their seizures. And then the last one is looking at poor control of their seizures. They then looked at some sleep parameters, including some sleep parameters in a sleep study, and found some interesting things. Mainly that total sleep time, sleep efficiency, REM sleep, and the arousal index were all different in patients with poorly controlled seizures compared to patients with good control or who were seizure-free. So that patients with poorly controlled seizures, they sleep less. The total time that they sleep is less. They have a greater percentage of REM sleep throughout the night. They tend to have more arousals throughout the night, and they have more fragmented sleep overall. Okay, so if you have poorly controlled epilepsy, you're likely to have one or all of these problems. This lists a bunch of anti-seizure medications and their effect on sleep architecture, including what is the sleep latency, how does the medication affect sleep latency, arousal, stage 2, slow wave sleep, or stage 3 REM, and sleep efficiency. Anti-seizure medications are quite extensive. The list is very, very long, and their mechanisms are highly variable. In fact, most neurologists have to look up the mechanisms because there are so many meds and so many different mechanisms. So I don't want you to focus on the individual meds right now. I'm going to point out some common ones and some take-home points here. So just get an overall idea about what things look like here. And I'm going to summarize that for you real quick. This is what it means. So basically, every single seizure medication will decrease your sleep latency, okay, which is not surprising, right? You're going to fall asleep more easily if you have, if you're on these medications, because all these medications are pretty sedating, okay? In terms of arousals, stage 2, 3 REM, sleep efficiency, it's hit or miss. It's completely hit or miss. Some meds make it worse, some meds make it better, some increase your percentage of time in REM, some decrease your percentage of time in REM. It's not super important to memorize all those, but I want you to have an appreciation that all these different medications can have multiple different types of effects on your sleep architecture. And if you're on more than one anti-seizure medication, then the likelihood of it having an effect is even more. In terms of the sleep latency, the one exception to the rule is felbamate. You may not have heard of felbamate before. It's a newer medication, usually used in patients who have really bad epilepsy. But this is the one medication that can actually increase your sleep latency. So felbamate acts on the GABA and NMDA receptors. So it's understandable how maybe because it's acting on the NMDA receptors, it's a little more wake promoting. This is usually dosed 3 times a day. So in the morning, afternoon, and at night, right before you go to bed. And it's possible that because of this wake promoting activity on the NMDA receptors, it can worsen a patient's insomnia. So if you have a patient on felbamate, they're coming in, they're saying, oh, I'm having trouble falling asleep, it might be worth talking to their neurologist about moving the timing of their dose to an earlier time. I would definitely encourage you to talk to the patient's neurologist before doing that yourself. There can be some subtleties where they might not want to do that for whatever reason. As a general rule, this is how I think of anti-seizure medications. If there have been a lot of medication changes or adjustments, then sleep disordered breathing may have been affected in a very meaningful way. So definitely consider repeating a PSG or a sleep study. We all know that benzodiazepines can suppress respiratory drive, and that could affect sleep disordered breathing. But I also want to emphasize that benzodiazepines are frequently used in neurology to purposefully decrease your muscle tone. Okay, so if you have abnormal muscle tone, we may treat you with a benzo. And so that will obviously affect then your breathing. And if you have something like REM dependent obstructive sleep apnea, where tone is definitely an issue, it could worsen or it could improve your OSA. A commonly used medication for seizures is clobazam, which is a benzodiazepine. It's a little less sedating, but it definitely affects muscle tone. So that's probably the one you may see most commonly in your patients with epilepsy. As we saw for the arousal threshold, it might go up, it might go down, depending on the particular medication. REM sleep can also be affected on the particular medication. This is extra helpful to know in terms of patients with, again, REM-dependent obstructive sleep apnea, because if you're changing the percentage of time that somebody's in REM sleep, then you may change the severity of their OSA. And then 3 seizure medicines that I think are particularly important are acetazolamide, topiramate, and zonisamide. These are all carbonic anhydrase inhibitors, so they affect the patient's acid-base status. You may know, or you may learn this year, that acetazolamide is sometimes used in central sleep apnea to decrease the central events. And so if you have a patient who gets put on one of these medications or taken off of one of these medications, you may or may not see more central apneas. Be very mindful if the patient has central sleep apnea. Okay. All right. So going back to our initial quote from several years ago, this has been reinterpreted in modern times in terms of something called the vicious cycle. And so let's start here over with the yellow sleep disorder section. I don't have to explain to this group that if you have a certain sleep disorder, whether or not that be OSA, hypoventilation, PLMs, or a circadian rhythm abnormality, or insomnia, that results in sleep fragmentation. We just reviewed how different anticonvulsants or anti-seizure medications can cause sleep fragmentation. Sleep fragmentation then often results in more seizures. And if you have a seizure, you're likely to continue and precipitate another seizure, which then can cause more sleep fragmentation for various different reasons. Okay. After somebody has a seizure, you can be in a post-ictal state of sleepiness, for example. And if you have that during the day and you sleep 3 hours, that's then going to negatively affect your sleep consolidation and your ability to sleep at night. If you have a seizure at night, you can potentially have what's called post-ictal agitation or hyperactivity, where the patient's more wired and they're awake for prolonged periods at night, which then obviously affects your sleep quality. This can just cycle into itself, resulting in worsening daytime sleepiness. It affects your learning, it affects your behavior. If you're not sleeping well, you're more irritable, and then it affects quality of life for patients and their caregivers as well. I needed to include this statement for completeness sake. This is a statement from the International League Against Epilepsy. That is a large governing body in the epilepsy world. They have come out and have stated that sleep deprivation has been insufficiently studied as a seizure precipitant in individuals without epilepsy or as a risk factor for seizures in people with epilepsy. I want you to notice that sleep deprivation is different than sleep disruption and sleep fragmentation. And all they said was insufficiently. They didn't say it's not possible. We just don't have enough data to really say for sure. Experience would suggest to us that sleep deprivation is, in fact, a trigger and a precipitant for a lot of patients with seizures. Talking to families and patients, usually the thing that we hear most commonly about seizures is, I have a seizure when I don't get enough sleep or I'm really stressed. And so those are the two most commonly reported precipitants from patients directly. Seizures and epilepsy are an extremely heterogeneous group of diseases, so it's really hard to study. But the official statement from the ILAE is that it's insufficiently studied to really draw any conclusions. So let's talk more about what patients actually say about their sleep. So this first figure asked some adult patients with epilepsy some questions, and the other one asked some families and children some questions about their sleep. So for adults who had focal epilepsy, they asked, okay, over the last 6 months, 4 months, or last night, have you had any kind of problems with your sleep? And over the last 6 months and over the last night, those were statistically significant. So a lot of those patients show almost double the sleep problems compared to patients without epilepsy. When we ask a similar question to children or parents of children with epilepsy, they flushed it out a little more in this study. What they see is that parents and children, parents mostly, are concerned about their child's breathing. They look like they're struggling with their breathing for whatever reason. They're more likely to have parasomnias, and they're more likely to be tired during the day. All right, so let's jump now to everybody's favorite sleep disorder, obstructive sleep apnea. Okay, so the prevalence of OSA in children is roughly 1 to 5%. Adults is roughly 15%. I say roughly because when you start to then look into different risk factors, different countries, the numbers change significantly. So this is looking at everybody across the world. In the United States and North America, however, where there's a higher percentage of people who are obese, we're going to see more OSA than 15%. Okay, so that's just kind of a rough estimate. What I really want to emphasize to you here is that adult patients with epilepsy have roughly, irregardless of other risk factors, a 10% chance of having OSA. If you're a child with epilepsy, you have a 20% chance of having OSA. And if you have refractory epilepsy, which is defined as ongoing seizures despite being on 2 or more medications that are appropriately dosed and chosen, if you're on a lot of medications and still having seizures, your chances of having OSA increase to 30%. Okay, and this is independent of things like weight and other risk factors for OSA. So epilepsy is a likely risk factor for OSA, and patients with poorly controlled seizures or patients with refractory epilepsy are at an even higher risk for having OSA. So the way I think about it is, if I have a patient who comes in to see me, they're obese, they have heart failure, and they have epilepsy, that's like 3 whammies. That means I need to be really concerned about the possibility of them having OSA. So the real reason this matters is because we can do something about it. It turns out that if we treat OSA in patients with epilepsy, we can actually help to improve their seizure control, which is a really, really important concept because seizures can be deadly. You can die from having a seizure. And so by decreasing the number of seizures you have, you decrease somebody's chance of dying from their disease. This is a little bit of a complicated table. This first column is looking at epilepsy patients with OSA who are treated with PAP. The second column is looking at epilepsy patients with OSA not treated with PAP. And the third column is looking at epilepsy patients who did not have OSA. And I just want to direct your attention towards the bottom where it says responder. They defined this study a responder to be somebody who had greater than a 50% decrease in seizure frequency. All right. And what we see is that patients who were treated with PAP were more likely to have a decrease in seizures over time since they were started with PAP. Another way of looking at this is as follows. Epilepsy patients with OSA who were treated with PAP were 32 times more likely to have a 50% reduction in seizures compared to patients with epilepsy not treated. And then epilepsy patients with OSA who were treated with PAP were 6 times more likely to have a reduction in their seizures compared to epilepsy patients without OSA. So if you have an epilepsy patient and you treat them, you can help in the vast majority of your patients to have better seizure control, which is a very, very important thing. All right. This is an important paper I think everybody here should read because I think this starts to illustrate where the field of sleep medicine is going as a whole. So this was a special article titled Metrics of Sleep Apnea Severity Beyond the Apnea-Hypopnea Index. This really emphasizes that the AHI is not the end-all and be-all for sleep apnea. It doesn't provide clear answers in terms of what we should be looking at instead, but it kind of outlines where further research is needed and asks a lot of really, really good questions. We've all seen patients who have really, really mild OSA or terribly sleepy. We treat them and they feel wonderful. It can be life transforming for them. And then we've seen patients who have horrible, horrible OSA. Their AHI might be 100. We treat them, they still feel kind of lousy. Right? So the AHI doesn't explain everything. We really need to think about the clinical context of certain patients. I mentioned this because in patients with epilepsy, even though somebody might have more mild sleep disordered breathing, it might actually be worth being more aggressive in their treatment because the AHI might not really capture everything that's going on. This is particularly important to keep in mind when we're talking about epilepsy patients or epilepsy in patients or in pediatric patients, because in pediatrics, if you have OSA, a lot of times we will recommend things like adenotonsillectomy or surgery. We tend to reserve that more to more moderate to severe OSA, but in epilepsy kids who have OSA and mild OSA at that, we do sometimes think about doing surgery in those kids because it's possible that, if we do surgery, we really help and are aggressive towards treating their sleep disordered breathing, we can make a really nice impact on their seizure control. And that's a common question and conversation that I have with my sleep colleagues, ENT, other neurologists, and epileptologists. There are no clear answers, but I just want to emphasize to everyone, the AHI is not the end all, again, and be all of OSA. All right, so talking more about patients with really bad epilepsy, sometimes patients with refractory epilepsy, we will consider surgery. So sometimes we will remove part of the brain, sometimes we will disconnect parts of the brain, sometimes we will implant devices into the brain, including like a DBS, a neurostimulator, or a VNS or vagus nerve stimulator. And the VNS is what I want to spend the next couple of minutes talking about. So a vagus nerve stimulator is kind of like the hypoglossal nerve stimulator. So everybody has heard of that in sleep medicine. We're using it more often now in certain patients. And it's basically a device that gets implanted into the skin. And there's a small wire that goes up into the left neck and attaches to the vagus nerve. The VNS will then intermittently deliver a stimulus, an electrical stimulus, throughout the course of the day or night, depending on how you program it. And then if somebody is having an active seizure, you can swipe the device with a magnet over their chest, and it delivers an extra stimulus. It's kind of like giving a seizure patient who's having a seizure Ativan or lorazepam or a benzodiazepine to try to abort the seizure. It works like that. Now, this device is not without side effects. And so this is the part that is really important for everyone here to know. When we look at what happens before and after VNS implantation, especially in kids, because kids are the ones who tend to get VNSs more than adults, what we see is this. So this took kids before and after their VNS was put in. Before their VNS was put in, about 30%, 29% of kids had OSA as per pediatric criteria, which goes along with what we said before, right? About 30% of all patients with refractory epilepsy have OSA. After they put the VNS in, that number jumped up to 86%. That is a huge, huge number. Right. Additionally, when we look at mild, moderate, or severe, what we notice is that before the VNS was put in, nobody had severe OSA. And then after, more than a third of kids were given severe OSA from their VNS. Okay. This is something that I point out to my epilepsy colleagues very often when we're talking about VNSs in terms of screening for sleep disordered breathing before the VNS, and also having a very, very low threshold if you do have the VNS to do a sleep study to see if the device is actually causing a problem with your breathing. What does this look like in practice? What does this look like on a sleep study? So this is a 75-second page where we see two respiratory events. They look like they're probably obstructive apneas. I see some effort in the chest and abdomen, and then pretty much no flow in the thermistor and transducer. So apnea is here and here. And then in the chin lead, you see this increased activity in the chin lead. This increased activity in the chin lead is actually when the VNS is going off, when it's delivering that stimulus. Now, looking at this page, you may not be able to really appreciate that. You may just think, oh, there's a little bit of a movement or muscle, something going on. How do I know that that's truly the VNS? Well, again, if we vary how we're looking at the same data and we zoom out this time instead of zooming in and look at things over 300 seconds, okay, 5 minutes, what we see is this. We see a very, very regular pattern of obstructive apneas that are time locked to this increase in chin EMG. So there's nothing physiologic that can make something happen this regular. This has to be a device. Okay, this has to be the VNS. And so the chin is actually showing some artifact because when the VNS is going off, it does cause some contractions in the airway muscles and around the neck period, or neck area. All right. Now, it's a lot easier when you can see the EMG artifact in the chin, right? It makes it pretty clear, but sometimes you don't always see artifact in the chin. And because of this reason, a lot of labs, including ours here in St. Louis, we've started to add an extra EMG lead over the left neck in our patients with a VNS. So if you look up here, this is, I believe, 5 minutes a page. If you look at the chin EMG, you don't really appreciate a significant change, right? It looks pretty constant throughout this entire page. But what you do see is where it says VNS, this is that extra EMG lead. You can very clearly see this like triple blob pattern, okay? And this is where the VNS is going off, okay? So it can be difficult to know if you don't have that artifact in the chin EMG, whether or not the events that you're seeing are related to the VNS or not. So here we see an obstructive hypopnea. We have a decrement, we have a desat. This is an obstructive because there is some snoring. It's kind of hard to see in this right here, but there's snoring. Here we have another decrement of flow, but no desat or arousal, so we can't score it as anything. And then over here we can score it because there's a 3% desat and an arousal. Okay, so because you might not always see the VNS being activated, it might be hard to know, well, to what extent is the OSA coming from the VNS and to what extent is the OSA coming from the patient's baseline OSA? Because we know, again, at baseline refractory patients, the chances of them having OSA is about 30%. And that's where the VNS on-off sleep study comes into play, which can be very, very helpful. So this is looking at this is a summary over the course of the entire night, looking at staging, body positioning, respiratory events, desats, leg movements, and there's no actual pressure there. During the first half of the night, what we did in this patient was we kept the VNS on. And what you can see under the respiratory events is that we have lots and lots of events when the VNS is on. Halfway through the night, we turned the VNS off. And the way we did this was by taping a magnet over the left chest where the device is, and that actually turns it off. And it does take a little while for it to turn off. You can see a few little residual events, but then for the rest of the night, no obstructive events at all. Okay, so this patient has VNS-dependent obstructive sleep apnea. And this is a way to kind of tease that out. Now, I wouldn't advocate turning off patients' VNSs just on your own. You definitely want to check with your patient's neurologist about whether or not that would be even safe. Okay, there are some patients who it wouldn't be considered safe, and we wouldn't want to do a study like this. But for the vast majority of patients, I would say we can do this on probably 90+% of epilepsy patients. So let's say you see something like this in an epilepsy patient who has a VNS. You're like, oh no, the VNS is causing the sleep disordered breathing. What am I going to do? Well, it's definitely a conversation with the patient's neurologist, right? You got to start there, let them know what's going on. And we have a few options. So you can consider PAP. Okay, they are obstructive type events in this situation. You can consider oxygen, high flow, which is a newer modality that a lot of places are starting to use. In kids, sometimes we will consider doing surgery. The easiest option by far would be to turn the VNS off at night. So the newer VNS models, you can just turn it off. It's a programming thing. And if you have that option, that's fantastic. Then you kind of resolve the issue there. However, there are some patients who, let's say they only have seizures at night. You probably don't want to turn it off then, right? So you got to talk to the neurologist and have a reasonable conversation about how this might be helpful. The other option you have is you can ask your neurologist, hey, can you decrease the VNS setting so that's not causing these events? This was a really interesting study. It was a case report out of Seattle where they did what I like to call a VNS titration polysomnogram, where throughout the night they made small adjustments to the VNS settings to see what combination of adjustments or what settings would result in a decrease in OSA events. So that's always an option. All right, we're going to take just a couple, maybe the next 5 minutes to talk through some nocturnal spells. I'm going to try to leave a few minutes available for questions. So I don't want to go into all the different types of potential spells because that's beyond this talk, and we would need several talks to kind of go into everything. But what I want to do right now is kind of provide a framework, an organizational framework, if you will, about how I think about nocturnal spells and how I approach taking care of these patients. So thinking about nocturnal spells in general, the reason I use the word spells is because spells does not imply a specific etiology. Okay, it doesn't imply seizures, it doesn't imply sleep-related rhythmic movements, it doesn't imply anything. It's generic enough where it's all-encompassing. And I think it's important to use that term when you're talking to patients, because patients might come in and say, oh, I was told I had a seizure last night. And it doesn't necessarily mean it was a seizure. Maybe it was a sleep-related problem and it wasn't. So I would encourage everybody, use the term spell until you're confident of a diagnosis. All right. In terms of spells that can occur around sleep or while falling asleep or waking up, we have hypnic jerks, which I know a lot of people know about, rhythmic movements. This is more commonly seen in pediatrics. You can have head banging or head turning as a kid is falling asleep or in light sleep, foot tremor, different hallucinations, and then Sandifer and hypercapexia occurs more in babies. Sandifer tends to be related to reflux, and with stiffening, hypercapexia is like an exaggerated startle. In non-REM sleep, we can see more sleep myoclonus. We classically see the parasomnias arising out of stage 3 sleep. They can look like sleep terrors, sleepwalking, confusional arousals, etc. We also see a lot of PLMs during non-REM sleep. In REM sleep, we can also see nightmares, RBD, sleep paralysis, and then enuresis and sleep talking can occur pretty much in any stage of sleep, and restless sleep as well. This is important to keep in mind because this will suggest if you take a history on a spell and you get a detail about the timing of the spell, does it occur in the early part of the night versus the early morning hours, that should narrow your differential. And then you should kind of start crossing things off of your list here. In neurology, for our neurology residents, one of the first skills that they develop when they start residency is how to take a good history on a spell or possible seizure. And as sleep physicians, seeing a lot of patients with nocturnal spells, you need to be able to take a good history too. So the trick here is to ask a lot of questions, okay? What did the spell look like, okay? Was it involving part of their body? Was it involving their entire body? Was it just their arm? Was it both their arms? Were those movements rhythmic or were they non-rhythmic? Were the eyes open? Were the eyes closed? Was there any head or eye deviation? Head or eye deviation is more likely to suggest seizure. Was it associated with urinary incontinence? For example, urinary incontinence during an event can more likely suggest seizure. But this is an interesting fact that's written about in some older studies. In young boys, or I should say in boys in general, more so than girls who have sleepwalking, boys tend to urinate in unusual places in the house for whatever reason. I don't know why. It doesn't happen as often to girls. So the story you might get is, oh, I thought they were sleepwalking and then they urinated in the closet or some unusual place. That's not a part of the history that the family or the patient is readily going to offer you because they're often embarrassed, but it is a question that you should ask, because if you get that part of the history, then it's more likely to suggest sleepwalking and a parasomnia. Was the event associated with flushing and or sweating? This can be helpful for sleep terrors. There's an autonomic response that takes place for sleep terrors, and that's something we often see. How long did the event last? Was it a few minutes, or did it last 20 minutes? If it was just a couple seconds to a minute, that's more likely a seizure. If it lasted closer to 20 minutes, it's more likely a parasomnia. Did the spell evolve? Evolution would suggest possible seizure. Does it happen once through the night, or does it happen multiple times through the night? And then probably the most important question to ask is, does it look the same every time? This is asking if the event is stereotypic. If it is stereotypic, then it is more likely to be seizure. Parasomnias tend to look different a little time, every time. Sometimes you get a little sleep talking, sometimes a little sleepwalking, sometimes you might sit up in bed, sometimes you might stay laying in bed. It varies every single time. Getting all this information is very helpful because then you can apply it to this FLEP scale. So this is a really helpful scale that kind of organizes those concepts that I think everybody should keep in their back pocket. This is called the frontal lobe epilepsy and parasomnia scale. And so basically what you do is you ask the patient all those questions, and you can ask them more specific questions that are listed here, and you assign a score for what their answers are. Okay, you can have more negative numbers and you can have more positive numbers after you sum it all together. And if you're more negative, that's more likely to suggest a parasomnia. If you're more positive, that's more likely to suggest a seizure taking place at night. Now, there are some gray patients right in the middle here between 0 and 5 who have overlap between both features. And these are the patients I tend to see. And so what do you do if the diagnosis still isn't clear? Well, you can ask the patient or the family to try videotaping the spells. Okay, a video is worth a lot more than just the patient describing it to you. You can consider getting a sleep study with a full montage EEG. Just recognize that even if you capture the event and even if you capture a seizure and it's a frontal lobe seizure, the EEG is likely to still be normal. And that's because the surface EEG can't see that deep into the brain. All right. You could try a medication. But just remember that clonazepam, which we often use for parasomnias, treats both parasomnias and seizures. So you might mask some things. And if you're still not sure, refer to neurology. All right. All right. Well, if we don't have any questions, I would say feel free to email me if you want to talk more or if you have a question. Again, thank you for inviting me to talk, and hopefully everybody learned something.
Thank you, Dr. Rudock, and thanks to everyone who attended. We appreciate it. Oh, there is one question in the chat. Did you see that?
Yes. So the question is, what other forms of neuromodulation do you find useful in sleep medicine? So the neuromodulation is generally considered to be the deep brain stimulator, a neuromodulating device, which is something where you implant into the brain and it senses when a seizure takes place and delivers an extra electrical stimulus when the seizure takes place, and then the VNS. For the neuromodulator and the DBS, the deep brain stimulator, it doesn't, at least right now, look like that negatively affects sleep in very significant ways. It's the VNS that is probably the biggest culprit. And so with the VNS, because it's affecting, again, the vagus nerve that controls airway muscle tone, and your palate tone sometimes can be affected. And so what you'll notice if you're talking to a patient who has a VNS is they're going to be talking normally, and then part of their speech will suddenly change, and that's when the VNS is being activated because it's affecting their palate and the back of their airway. So oftentimes what I find is the best approach is for these patients who have VNS-induced OSA is turning the VNS off at night or just adjusting the VNS settings. That's been successful in the patients that I've taken care of with that pretty much every time so far, but it might not be. You might have to adjust the VNS and also do something like PAP. The next question is, have you found the Inspire device to be helpful in pediatric patients? So the Inspire device, or the hypoglossal nerve stimulator, is still not FDA approved for pediatric patients. There are some studies that are taking place in pediatric patients with Down syndrome, which is exciting. But because it's not FDA approved, we really just don't know yet. But the preliminary data and the preliminary studies would suggest that it could be helpful.
There was one question. Are there specific criteria for SHE that are specific? Are there criteria for SHE that are specific?
Yes, there are diagnostic criteria. And it will depend on the EEG, the clinical semiology, and also it can be genetic. And so there can be specific genetic mutations that are associated with SHE, or sleep-related hypermotor epilepsy. But again, if you think that you have a patient with SHE, you should absolutely refer to a neurologist, because that neurologist is going to want to put the patient on anti-seizure medications, probably get more extensive EEG testing, maybe genetic testing, and for sure they're going to want to get a brain MRI, because sometimes if you have because it tends to be focal, it could indicate a brain mass. In neurology, any kind of focal seizure is brain mass until proven otherwise, and so that's why we always get imaging on those patients.
Okay. Thank you so much, Dr. Rudock. And since we're a few minutes past the hour, we will end the session. Thank you to everyone for attending, and thank you, Dr. Rudock. We appreciate your presentation.
Thank you. Have a good day, everyone.
That was fantastic. Thank you so much.